Okay, we'll talk about today uh, female infertility from Sperrof 9th editions. What is infertility? Infertility is defined as 1 year regular unprotected intercourse without conception. The terms of fertility is used interchangeably to describe women or couple who may not be sterile but exhibit decreased reproductive efficiency. Okay. Approximately 85 to 90% of healthy young couple conceive within 1 year, most within 6 months. Infertility therefore affects approximately 10 to 50% of couples, represent an important part of clinical practice. What is fecundability? Is the probability of that a cycle will result in pregnancy. Fecundity, the probability that cycle will result in a live birth. The difference is fecundability is result in pregnancy, fecundity is result in live birth. Epidemiology. Okay. The overall long-term decline in the US birth fertility rate has been attributed to several factors. First, greater interest in advanced educational career among women, later marriage, more frequent divorce, improvement in contraceptions, access to family planning service, delayed childbearing, decrease in family size. Okay. What is the role of aging and infertility? The effect of aging on female infertility are perhaps best revealed by the results of studies in natural populations wherein couples reproduce without voluntary restriction. Although revealing this other data derived from the studies in natural population may not reflect the biological reproduction for several reasons. Women who have children when young may be less inclined to conceive again in later life. Coital frequency often declines as the age will increases, reflecting decreasing desire or lack of partners. The incidence of subclinical abortion is unknown. The cumulative impact of other diseases or conditions that can adversely affect fertility, example pelvic infection, leiomyomatous, endometriosis, is greater in older women. Overall fertility rate are 4 to 8%, that is lower in women aged 25 to 29 years, 15 to 19% lower in those aged 30 to 35 years, 26 to 46 lower in 35 to 39, 95% was 40 to 45 years. Okay. In human, the follicular depletion number of oocyte peak around 20th week of gestation, when approximately 6 to 7 million of oocyte arrested at the first meiotic prophase are found in the ovarian cortex. Afterward, regulated apoptosis starts and an irreversible decline in the germ cell population will happen. The number of oocyte decline to 1 to 2 million at birth and 3 lakh to 4 lakh by puberty. Over the next 35 to 40 years of reproductive life, only about 400 oocyte will ovulate, the rest being lost through the atresia. By age 40, number of follicles sinks to approximately 25,000. Remember, 20. The first attempt to define age-related pattern of follicular depletion was based on analysis of combined data older monomorphic city. The current working model describes gradually increasing rate of follicular depletion, in which the pace of decline increases as the number of follicles remaining decrease, supported by evidence paracrine vectors secreted by the primordial follicle, inhibit recruitment, regulate the size of the resting follicular probe. Endocrinology. Toward the end of the reproductive period, the serum FSH level begin to rise, while luteinizing hormone concentration remain unchanged. Remember, toward the end of the reproductive period, the serum FSH level begins to rise, while luteinizing hormone concentration remain unchanged. LH remain unchanged. This occurred before any discernible change in menstrual regularity. The subtle monotropic rise in circulating FS concentration is most apparent during the intercycle transition, when the corpus luteum regresses, menses begins. This could be result from age-related changes in the pattern of pulsatile kisspeptin and gonadotropin releasing hormone secretion, or from progressive follicular depletions and decreased inhibitory feedback by ovarian hormone. The weight of available evidence, a variety of studies, animal and women identified. Okay. The bulk of available evidence indicate that progressive increase in FSH concentrations associated with reproductive aging result from a progressive decrease in the level of feedback inhibitions from the smaller cohorts of follicle recruited from a shrinking follicular pool. Circulating follicular phase, inhibin B level derived from primary from small under follicle decrease as or even before FSH concentration begin to increase. The inhibin B will decrease before FSH start to increase. Inhibin A also decline, but only in the later stage of reproductive aging. After the onset of menstrual irregularity, inhibin A will be increased. First inhibin B, then FSH. First inhibin B, then FSH. Inhibin B, then FSH, then inhibin A. Okay. In both inhibins selectively inhibit pituitary FSH secretions. Consequently, FSH level rise progressively as inhibin production from smaller cohorts of aging follicle decreases. Most noticeable in the early follicular phase, whereas the declining in inhibin production also could reflect a decrease in functional capacity of older follicle. The observation that pre-ovulative follicular fluid inhibin concentration is similar in younger and old cycling women, such that number of remaining follicles is more important. Ovarian steroid hormone don't play a major role. The initial rise in FSH level precedes any measurable decrease in estradiol level by several years. Follicular phase estradiol level in older cycling women generally are similar to the younger women, often higher. Luteal phase estrogen progesterone level also don't seems to change consistently with the advancing age. Moreover, sporadic ovulatory cycle in aging women serum consider estradiol progesterone compared to the observed younger women. As age and FSH level increase, the follicular phase becomes shorter. LH level and luteal phase duration remain unchanged. As the follicular phase certain, estradiol level rise earlier, suggesting that higher FSH levels stimulate more rapid follicular development. However, careful study have shown that early rise in estradiol level result not from accelerated follicular growth but an advanced follicular development at the beginning of the cycle. Advanced follicular development and early selection of the remaining follicle. The earlier increase in the follicular phase FSH level also frequently result in more than one dominant follicle, explaining the higher prevalence of dizygotic tuning in older cycling women. Very important statement they have to tell. The earlier increase in the follicular phase FSH level also frequently result in more than one dominant follicles. That will explaining the higher prevalence of dizygotic tuning in older cycling women. Okay, though the reproductive aging quite already is quite advanced when the first clinical signs appear. Cycle remain regular, but overall cycle length variability decrease gradually, reaching nadir at an average of age 42 years when fertility is at or near an end. However, women generally take notice only when the cycle becomes irregular, making beginning of the menopausal transition. Menopausal transition begin at an average age of 46 years but can arrive early as a 34, late as 54. The average cycle length variability increase steadily. Okay. Regardless of the age interval from the loss of menstrual regularity to menopause is relatively fixed, spanning after 5 to 6 years. The age of genetic reproductive aging, bearing the disease destiny removal of ovarian tissue. Any important environmental insult. There is a good correlation between the menopausal age in mother and daughters between sisters, such that genetic factor play an important role in determining the menopausal age. Approximately 10% of women become menopause by the age of 45 years. Probably because they endowed with smaller than average ovarian follicular pool that is functionally depleted in early age. Pedigree analysis has revealed that genetic features of earlier menopause age 40 to 45 year premature ovarian period similar, suggesting a dominant pattern of inheritance through maternal paternal relatives. The same genetic factor that determine the age at menopause also likely to determine the age of reproductive milestone. Gene affecting reproductive hormones FSH, FSH receptor, LH, LH receptor, CYP17, CYP19 are involved in the initial growth of follicles. GDF9 bone morphological protein, 15 GPR3 important follicular functions mutations are rare in humans, but polymorphism could increase the rate of follicular recruitment, depletions, thereby affect the length of reproductive life. Variation in the other gene encoding DNA binding protein, transcription factors, NOBOX, LHX white, RNA binding protein, EPAB, CP nanos expressed during oogenesis could be affect germ cell formation. Mutation causing primary ovarian failure have been identified in few women. Variation in the other gene who link to primary ovarian also might affect the rate of follicular depletion in the normal woman. Adam TS19 FOXL2. Aging follicle and oocyte, whereas the number of remaining ovarian follicles steadily decline with increasing age. Observations in stimulated cycles is that aging follicle also become progressively less sensitive to gonadotropin stimulation. As age will increase, the total dose and duration of treatment required to stimulate multiple follicular developments increase. The rate of rise and peak of estradiol level decrease. Refer to the smaller cord follicle that can be recruited. However, the amount of estradiol secreted the follicle that do emerge, grow to maturity appear comparable to that of younger women. Although a decrease in exogenous SSG induced ovarian androgen production can be demonstrated before the age of 30, circulating estradiol level remain normal throughout and beyond the reproductive years, probably because rising in FSH level able to compensate. Study of ovarian follicular development, puberty follicular fluid hormones in older and younger cyclic women don't suggest any age-related decline in follicular functions. One growth and development pre-ovarian follicular. The available evidence indicate that both age-related decline in female fertility and the increase in risk of miscarriage can be attributed to increase in proportions of abnormal oocyte in an aging and shrinkage follicular fluid. Aging and uterus. Donor live birth rates in donor egg IVF cycle related to the age of the donor, not the age of the recipient. Remember, if you go for IVF cycle, donor egg IVF cycle to the age of the donor, not the age of the recipient. Aging and male fertility. Overall, the available evidence suggests that negative correlation between male and age and pregnancy rate. The time to conception increase with male age. However, because there is little or no overall measurable decline in the male fertility before age of 45 to 50, male factors generally contribute relatively little to the overall age-related decline in fertility. Ovarian reserve and its assessment. The term ovarian reserve refers to the size and quality of the remaining ovarian. First is the ovarian reserve is the size and quality of the remaining ovarian follicular pool. The ability of the ovary to respond to exogenous gonadotropin stimulation, which are related concept. So what is ovarian reserve? Ovarian reserve means what is the size and the quality of the remaining ovarian follicular pool. The ability of the ovary, what is the abilities of the ovary to respond exogenous gonadotropin stimulation. Since the major effect of aging on a woman's reproductive potential is through declining oocyte number and increased oocyte aneuploidy, the concept of ovarian is relevant from female reproductive aging. There are two intentions for ovarian reserve testing. One is to predict the fecundity. Second is to gain prognostic information regarding the likelihood of successful response to ovarian stimulations in women undergoing infertility treatment. Likelihood of fecundity of the pregnancy, how many live birth rate. Like of all screening tests, ovarian reserve tests are aimed to identifying the individuals at risk of a disease. In this case, diminished ovarian reserve. It is important to emphasize that such tests cannot and don't establish a diagnosis of diminished ovarian reserve. They only identify women are more likely to exhibit a poor response to gonadotropin stimulation and potentially have a lower likelihood of achieving pregnancy with treatment. The value of screening test depends on its validity, describe the sensitivity specificity. For major ovarian reserve test threshold should have a high specificity so as to decrease false positive results. Incorrectly categorize the patient with normal ovarian reserve has been. Therefore, avoiding overall aggressive treatment, inappropriate recommendation, abandoned pursue, adoption, oocyte donations, normal ovarian reserve treatment is unrecognized. If vegetation correctly, most useful test. Ovarian include both biochemical and ultrasonography measure of the size by inference the quality of the ovarian follicular pool. The biochemical tests include both basal measurements such as FSH, estradiol level, inhibin B, anti-Mullerian hormone, and the provocative tests such as the clomiphene citrate challenge test. What are the ovarian reserve tests? FSH, estradiol, inhibin, serum AMH, provocative test, clomiphene citrate challenge test. Ultrasonographic measures of ovarian reserve include the antral follicle count and ovarian volume. It should be noted that both biochemical and ultrasonographic marker of ovarian reserve have poor predictable value for conceptions. Women should not know that they can conceive spontaneously, should not be denied fertility promoting treatment, including ART, based solely on finding of decreased ovarian reserve. The serum FSH concentration was one of the most earliest commonly used tests for ovarian reserve. Since an isolated increase in FSH level is one of the earliest indication of reproductive aging in women, it was an obvious choice for identifying women with diminished ovarian reserve. As a marker of ovarian reserve, serum FSH concentration is best obtained during the early follicular phase, day 2 to day 4 follicular FSH. However, serum FSH concentration has a wide intra and inter-cycle variation, limiting its value as a screening test. So, moreover, because of it is a wide and inter-cycle variation, that will limiting its value as a screening test. Moreover, FSH value vary with assay methods. Although value obtained with different assay correlate very well, absolute value can differ significantly. Values also vary with the reference standard. Numerous studies investigated that relationship between the cycle day 3 FSH concentration or FSH bar LH ratio and IVF cycle outcomes, all observing that these measures correlate with all ovarian response to exogenous gonadotropin stimulation and to a lesser extent with likelihood of success. As FSH value increases, the peak estradiol level, the number of oocytes retrieved, the probable pregnancy level will decline. With current assay using FSS greater than 10 to 20 international would have a high specificity for predicting poor response to stimulation, but the sensitivity is very low, decrease with threshold value. Because of FSS level can vary significantly, many clinicians prefer to repeat the test. Not surprisingly, consistently high value are associated with poor prognosis, but a single elevated FSH concentration more than 10 international unit does not have a high specificity for predicting poor response to stimulation or failure to achieve a pregnancy. The serial testing in efforts to select an ideal cycle for treatment does not improve outcome in women with fluctuating FSH concentration. The basal serum estradiol concentration by itself has a little value as an ovarian reserve test, but can provide an additional information that helps in the interpretation of the basal FSH level. An early elevation in serum estradiol reflects advanced follicular development. An early elevation of serum estradiol reflects advanced follicular development and early selection of dominant follicle. What is the meaning of elevation of serum estradiol? If serum early elevated, serum estradiol will there, that will reflect there is some advanced follicular development and the early selection of dominant follicle as classically observed in women with advanced reproductive aging, and will suppress that if estradiol level will suppress that will suppress FSH concentration, thereby possibly masking an otherwise obviously high FSH level. So when the basal FSH is normal, that is why it is FSH normal, because the estradiol concentration is so high that will suppress the FSH, that will mask the high FSH level, as because of advanced age, that will cause poor response stimulation and increase the chance of pregnancy will decrease. When both FSH and estradiol are elevated, ovarian response to stimulation is likely to be very, very poor. Okay. So if both are elevated, that is poor response. If FSH is normal, estradiol is high, that also causes a estradiol, because of masking effect of estradiol, it will also poor response. CC challenge test. The clomiphene citrate challenge test is provocative and possibly more sensitive test of ovarian reserve that probe the endocrine dynamic of the cycle under both basal and stimulated condition. Before it is cycle day 3 FSH estradiol, after cycle day 10 FSH treatment with clomiphene citrate 100 mg per day, cycle day 5 to day 9. The smaller follicular cohort in aging women produce less inhibin B and estradiol, resulting less negative feedback inhibition on the clomiphene induced pituitary FSH release. That will cause an exaggerated increase in the FSH concentration. So remember, if the patient had already in ovarian aging, that woman produce very less amount of inhibin B and estradiol. That will result in less negative feedback inhibition of the clomiphene induced pituitary FSH release, causing exaggerated increase in FSH concentration. Consequently, a frankly elevated cycle day 10 FSH concentration can identify a woman with DOR who might otherwise go on recognized if evaluated with basal cycle day 3 FSH estradiol level alone. Then anti-Mullerian hormone. AMH is produced by the granulosa cell of the preantral and the small antral follicle, beginning when primordial follicle start developing into primary follicle and ending when early antral follicle is diameter 2 to 6 mm. When AMH is produced from where? AMH is produced, anti-Mullerian hormone is produced by the granulosa cells of the preantral and the small antral follicle, beginning when the primordial follicle start developing into primary follicle, and the end will be when early antral follicle reaching the diameter of 2 to 6 mm. The small antral follicle are likely the primary source because they contain larger number of granulosa cells and more developed microvasculature. Although it functions primarily as an autocrine and paracrine regulator of follicular development, AMH appear in measurable amount in the serum. The number of small antral follicle correlate with the size of the residual follicular pool. And AMH level decline progressively, becoming inactive near the menopause. Because of AMH derives from preantral and the small antral follicle, the level were thought to be gonadotropin independent and exhibit the little variation between the cycles. So, because AMH derived from preantral and the small antral follicle, the level were thought to be gonadotropin independent and exhibit little variation between the cycles. However, recent studies suggest AMH levels decrease with the use of oral contraceptive and GnRH agonist. In the early clinical study, AMH has been assessed using two different commercial kits. In general, the IVF population, the low AMH threshold value is 0.2 to 0.7 nanogram per ml, have had a 40 to 97 sensitivity, 70, 80, 92 specificity, 22 positive radical, poor response to stimulation. If less than 3 follicle or 2 to 4 oocyte, but have neither sensitivity nor predicting pregnancy. AMH is very promising screening test for DOR, but is likely to be more useful in general IVF populations or women are high risk for DOR than women at low risk for DOR. Low threshold value have good specificity for poor response to ovarian stimulation but not predicting pregnancy. Antral follicle count, another things, reproductive age women have estimated 20 to 150 growing follicle in the ovaries at any one times. Although only those large enough to be imaged, that is more than 2 mm, can be visualized by transvaginal ultrasonography, antral follicles are FSH sensitive and can progress to more advanced stages of development when stimulated with exogenous FSH. The histological study have revealed that number of small antral follicle in the ovary is proportional to the number of primordial follicle remaining. Therefore, as the supply of primary follicle decrease, the number of visible small antral will also decline. The antral follicle count, total number of antral follicle count measuring 2 to 10 mm in both ovary, thus provide an indirect but useful measure of ovarian reserves. AFC correlates to onset the menopausal transition, it is related to the number of follicle remaining. Low AFC, high specificity for predicting poor response to ovarian stimulation and treatment failure, making it useful test but low sensitivity limit the ovarian clinical utility. What is the effect of ovarian volume? Not surprisingly, ovarian volume decrease with progressive follicular depletion. However, the measure has higher inter-observer variability because most of the studies of ovarian volume have excluded women with ovarian pathology such as endometrioma, PCOS. These have limited generalizability. Ovarian volume, how you will calculate? Length into width into depth into 0.52, that is ovarian volume. Generally correlate with the number of the oocyte retrieved but poorly with pregnancy. A low volume, that is when we will call as a low ovarian volume if it is a volume of less than 3 ml, and when limited clinical utility. Other tests for ovarian reserve test, numerous tests has been FSH, stimulator estradiol, and MH level. However, the available evidence does not justify the complexity and higher cost of this test, since they are not found to be better predictor of the response to ovarian stimulation or pregnancy than basal FSH, AMH, and AFC. Combined test for ovarian reserve test, AMH and inhibin B. Summary. In summary, currently there is no ovarian reserve test that predict the likelihood of spontaneous conceptions for a regularly menstruating woman. For the purpose of predicting response to ovarian stimulation, the lack of uniformly accepted definition of diminished ovarian reserve, despite a number of attempts, remains a problem. In order to predict the success of ART, the ideal ovarian reserve test should be yield consistent results, be highly specific to minimize the risk of incorrectly categorizing normal women as having DOR. Currently, AFC and AMH are replacing the basal FSS level as the most commonly used ovarian reserve test in clinical practice. Although ovarian tests are capable of predicting response to exogenous gonadotropin stimulation reasonably well, whether the information can truly affect the outcome is uncertain. Individual FSS dose based on ovarian reserve testing does not seem to improve live birth rate. Moreover, increasing gonadotropin dose does not improve response predictably, nominated DOR, probably because a small cohort of responsive antral follicle is the limiting factors. No amount of stimulation can increase that appreciably. None of the ovarian tests currently used in accurate predictor of a pregnancy in IVF cycle, with the possible exception when extremely abnormal threshold value are applied, which result in very low sensitivity. The best overall strategy would seem to limit ovarian reserve testing to women at increased risk for having diminished ovarian reserve. Apply high specific threshold value to minimize the risk for positivity plot. Ovarian reserve testing can be justified for women with any of the following characteristics. Remember, this table is very important for in the Sperrof 9th editions. They have specifically mentioned who are the persons, who are the patients, those patients you want to do ovarian reserve testing. First thing, age. If the age is over 35, first thing, if you know if age is over 35. Second is unexplained infertility to identify unsuspected loss of ovarian reserve, family history of early menopause, previous ovarian surgery like ovarian cystectomy or drilling, unilateral oophorectomy, chemotherapy, radiations, or patients have history of smoking, demonstrated poor response to already seen a demonstrated poor response to exogenous gonadotropin stimulation. So age, unexplained infertility, family history of early menopause, previous ovarian surgery, cystectomy, drilling, unilateral oophorectomy, chemotherapy, radiation. Ovarian reserve test always should be interpreted with a caution. Rigid application of test result is inappropriate recommendation for treatment or for no treatment, both must be avoided. An abnormal test result does not preclude the possibility of pregnancy, except perhaps when grossly abnormal. The test result should not be used to deny treatment, but only to obtain a prognostic information that will help to guide the choice of treatment based use of available resources. Although the probability of pregnancy may be low, many with abnormal test results will achieve pregnancy if they offer the chance. Ultimately, regardless of this prognosis, the success rate for any individual will be 0 or 100%. Guiding the principle of how will evaluation. Remember, how will evaluate a male female infertility patients. The four basic goal for management of infertility. First is to identify and to correct specific causes of infertility when possible. With proper evaluation and treatment, the majority of women will achieve pregnancy. Second management basic goal is to provide accurate information and to display the misinformation commonly gained from friends, mass media, and the internet. Provide emotional support during trying time. To guide a couple failing to conceive with other form of treatment, to alternative include IVF, the use of donor gametes, oocyte or sperm, and adoptions to help those who reject or fail treatment to come to closer. Lifestyle environmental factors. For couple attempting to conceive, there is a fair evidence to support recommendation for smoking suggestions and effort to achieve a BMI between 20 and 25 kg per meter square. The recommendation to limit alcohol consumption to 4 or fewer drinks per week and to limit caffeine intake to less than 200 mg per day also are reasonable and consistent with available evidence. So however, there have been no randomized trial demonstrating lifestyle modification. What are the lifestyle modifications you advise to the patients? Suppose he is a smoker, you have to advise smoking cessations. Suppose he has a BMI of more than 25, you have to advise the BMI should be 20 to 25 per kg per meter square. The recommendation to limit the alcohol consumption is 4 or fewer drinks per a week. She has a drinks, she can drinks, but at least 4 or less than 4 per a week. And the caffeine intake should be 200 less than 200 milligram per day. Okay. The normal reproductive efficiency in normally fertile couples cycle fecundity average 20%, does not exceed approximately 30%. Even coitus is careful time. Normally, a fertile couple's fecundity averages 20%, does not exceed approximately 35%. Time required for conception couple who will attain pregnancy. 3 months 57% will pregnant, 6 months 72, almost 1 year 85, 2 years 93%. A normal sperm can survive in the female reproductive tract and retain the ability to fertilize an egg for at least 3 and up to 5 days. But sperm can survive in a female genital tract minimum 3 days, maximum 5 days, but an oocyte can be fertilized successfully for only approximately 12 to 24 hours after ovulation. So, consequently, virtually all pregnancy result from an intercourse occurring sometimes within 6 days interval ending on the day of ovulations. If the person has do one sexual intercourse 6 days before the ovulations, within 6 days before on the day of ovulation they can conceive. So remember, the sperm survive 3 to 5 days, oocyte 12 to 24 hours. Okay. Causes of infertility. The major causes of infertility include ovulatory dysfunction, that is 20 to 40%, tubal peritoneal pathology is 30 to 40%, male factor also 30 to 40%, uterine pathology. Remember, uterine pathology is relatively uncommon. Okay. Many couples suffer from multiple etiologies. The prevalence of each causes of infertility vary with ages. Ovulatory dysfunction is more common in younger women than in older couples. Tubal and peritoneal factors are similar prevalence. Male factor and unexplained infertility observed somewhat more often in older couples. The distribution of the causes also vary with the duration of infertility and the level of care. Most of the couples seeking evaluation have been trying to conceive for 2 or more years, so few will be normally fertiles. Those with longer duration of infertility generally have more severe multiple problems and to congregate in tertiary care center. The average duration of infertility per couple seen in tertiary care center is 42 months, is twice that of a couple seen in the primary care center is 21 months. Predictability of the proportion of couple with easy treatable ovulatory dysfunction decreased from primary to tertiary. with more severe tubal and peritoneal factors. Okay. The human reproductive process is a complex process, but for purpose of evaluations, it can be dissected into most important basic concepts. Key component: human reproductive process. Sperm must be deposited at or near the cervix at or near the time of ovulation. It is then ascended into the fallopian tubes. Have the capacity to fertilize the oocytes. Ovulation of a mature oocyte must occur ideally on a regular reproductive basis. Ovarian factor: the fallopian tube must capture ovulated ova, effectively transfer sperm embryo. Uterus must be receptive to embryo implantation, capable of supporting subsequent normal growth and development uterine factors. Some infertility problems once considered insurmountable are now amenable to modern treatment, like IVF can effectively bypass irreparable tubal occlusive disease, irreparable tubal occlusive disease, and intracytoplasmic sperm injections can overcome even some abnormalities, severe abnormalities in human quality. The treatment aimed at increased gamete density, bringing together more than usual number of oocytes and sperm in the right place at the right time, can increase cycle fecundability for couples with age-related or other unexplained infertility, including ovarian stimulation with IUI or IVF. In women with primary ovarian failure, women beyond reproductive age, women without ovary, IVF using donor oocyte is highly successful. A substantial proportion of subfertile couples suffer from unexplained fertility, have a normal semen analysis, at least one patent tube macroscopically. Remember, this is the very important definition they have given as an unexplained infertility in Sperrof 9th editions. What is the definition of the unexplained infertility? Is the patient has, the male has a normal semen analysis, at least female has a one patent tube, and macroscopically normal appearing uterus and endometrium and regular menstrual cycle. Okay, these are the things that has to be there. Macroscopically normal appearing uterus, endometrium, regular menstrual cycle. Similarly, a rational treatment does not exist for some common cause of infertility: advanced female age, several tubal demise, idiopathic oligoasthenospermia. The scope of sequelae of the modern infertility evaluation have shifted focus from always making a specific diagnosis to using the most efficient, cost-effective test. Likewise, the focus of treatment for infertility also be shifted from systematic correction of the each identified factor to applying the most efficient, cost-effective therapy, which is often is ART. Indication for evaluation: when should a formal evaluation for infertility should begin? After all, most infertile couple are only subfertile, not truly sterile. Many will conceive eventually without treatment. Infertility has a significant spontaneous cure rate with that varies with female partner age, duration, past conception history, of the cause. The probability of achieving a live birth without treatment decreases with increasing age and duration of infertility. Overall likely pregnancy rate: the largest majority of spontaneous pregnancy occur within 3 years. Thereafter, the pregnancy success without the treatment is relatively poor. The couple has to conceive before generally have better pregnancies. Those have a near achieved pregnancy, causing it will affect them. Evaluation should be offered to all couples who have a failed to conceive after a year or more regular unprotected sexual intercourse. But a year of infertility is not a prerequisite for evaluation. Earlier evaluation is justified in the presence of a obvious risk factors like irregular infrequent menses, history such as irregular infrequent menses and history of pelvic infections, surgery or endometriosis, having a male partner with known or suspected poor semen quality. Remember, these are the points they can ask. Who we need an earlier evaluation? First one is the cycle has to be irregular or infrequent, history of pelvic infections, surgery or endometriosis, or having a male partner with known or suspected poor semen quality. Also is warranted after 6 months of unsuccessful report from over the age of 35 years. The education should be offered only a couple who succeed. Preliminary evaluation of the infertile couple: history and examination of the female partner, history of study history including gravidity, parity, pregnancy outcome, associated complication, menstrual history including cycle length, characteristic of onset and severity of dysmenorrhea, coital frequency, what is the coital frequency and sexual dysfunctions, duration of the infertility and result of any previous evaluation of the treatment, medical and surgical history including episodes of pelvic inflammatory disease and exposure to sexually transmitted infections. Previous abnormal cervical cancer screening results, current medication allergies, occupation use of tobacco, alcohol, other drugs, any medication and any allergy history, medical and surgical history, including the pelvic inflammatory disease, exposed to STD infections, duration of infertility, result of any previous evaluation and treatment, coital frequency and sexual dysfunction is very important. Coital frequency and sexual dysfunction, duration of infertility, previous evaluation and treatment, medical and surgical history, including episode of pelvic PID, exposure of sexual transmitted infections, previous abnormal cervical cancer screening, nasal subsequent treatment, current medication, allergy, occupation, use of tobacco, alcohol, smoking, family history of birth defect, mental retardation, early menopause, reproductive failure, symptom of thyroid, pelvic abdominal pain, galactorrhea, hirsutism, and dyspareunia. What are the physical examination finding? First of all important patient with and BMI, then thyroid enlargement, any nodule or tenderness, breast secretion, their characteristic signs of androgen excess, pelvic or abdominal tenderness, organ enlargement or mass, uterine size, contour, position and mobility, vaginal and cervical abnormalities, secretions or discharge, mass tenderness, nodular in the neck and cul-de-sac. Irregular infrequent mens indicate ovulatory dysfunctions. Previous treatment for cervical CIN or observation of a mucopurulent cervicitis or a cervicitis or cervical stenosis help to identify unusual women whom cervix may present obstacle. A history of previous cystoscopic or reconstructive uterine surgery or recently developing symptoms of menorrhagia suggests an abnormality of the uterine cavity. Previous uncomplicated first and second trimester pregnancy termination generally don't adversely affect subsequent fertility. Worsening dysmenorrhea, new onset of dyspareunia, physical pain and focal tenderness, cul-de-sac nodularity suggestive of endometriosis, a history of pelvic infection, septic abortion, rupture appendix, ectopic pregnancy, abdominal myomectomy and nexal surgery should raise the suspicion of tubal and peritoneal disease. Remember, these are the indication: history of pelvic infection, septic abortion, rupture ectopics, abdominal myomectomy and nexal surgery should raise the suspicion of tubal and peritoneal disease. The screening test. Cervical cancer screening is recommended for all sexually active women of a reproductive age who have a cervix. Cervical cancer screening is all sexually active women of reproductive age who have a cervix. The date and result most recently to be documented and new one was to be performed. The optimal method screening depending on the previous history is blood, RH factor, antibody. The SEOG recommended all women considering pregnancy should be offered a carrier screening for cystic fibrosis and spinal muscular atrophy as well as a complete blood count screening for thalassemia, hemoglobinopathy. Women with a family history of Fragile X syndromes, related disorder or intellectual disability suggestive of Fragile X syndromes, or women with premature ovarian insufficiency should be offered a Fragile X pre-mutation carrier screening. If she had a family history of Fragile X disorder, additional screening also may be indicated based on the family history or specific ethnicity. Ashkenazi Jewish population for an expanded carrier of screening a number of recessive disorder indicated. Couple with consanguinity should be offered. Genetic counseling to discuss with the increased risk of recessive conditions being expressed in their offspring. The limitations benefit of carrier screening. When a woman is found to be a carrier for specific conditions, a reproductive partner should offer screening accurate counseling regarding the risk of the affected child. If test is positive, reproductive officials donor gamete pre-implantation genetic diagnosis and prenatal diagnostic tests should be offered. All women attempting pregnancy with undocumented previous rubella infections. All women attempting pregnancy with undocumented previous rubella infections. All women attempting pregnancy with undocumented previous rubella infections and vaccinations should be tested for immunity and vaccinated if they are negative, as there has never been documented a case of congenital rubella syndrome attributed to vaccines. The CDC has determined that women need not avoid pregnancy for more than 1 month after vaccination. More than 1 month. The CDC also recommends that all women without history of previous infections or evidence of immunity, vaccination against varicella, chickenpox, receive 2 doses of vaccine, avoid pregnancy for 1 month after each dose. The sexual transmitted infections is recommended for all the women at moderate to high risk for infection. The decision regarding STI screening should be considered that the current recommendation from CDC include screening all pregnant women for syphilis, rapid plasma reagin, RPR, hepatitis B surface antigen, HIV, unless the woman declined later the first prenatal visit. The chlamydia, gonorrhea screening that is nucleic acid amplification based test is recommended all pregnant women younger than 25 years or older women at increased risk of infection. For women receiving insemination of donor sperm, ASRM considered the syphilis, hepatitis B, C, HIV, 1, 2, chlamydia, gonorrhea, and the CMV screening mandatory. Recommended screening human T cell lymphocyte type 1, type 2, discretion of the physicians. Insemination of donor inseminations. For male partner, women receiving insemination of donor sperm, the ASRM strongly recommends HIV 1 2, recommend other STI screening similar to that of female partner like gonorrhea, chlamydia. If there will be donor inseminations or donor oocyte, this they have to do chlamydia and gonorrhea testing. For the recipient of donor oocyte or embryo, their male partner, ASR recommends screening syphilis, hepatitis B, C, chlamydia, gonorrhea, CMB, gonorrhea, STLB type 1 and type 2. Remember, this is a very important point. You have to remember this. All these tests they should do. CMB, HIV, chlamydia, gonorrhea, and CMB. Any additional screening laboratory tests should be directed by the medical history and clinical judgment. Male factor abnormality of the semen quality. The evaluation of the treatment in male infertility are the focus, but must be addressed with semen analysis, register analysis to be done. Ovarian factor, overall disorder of ovulation account for approximately 15% of the problem in infertile couples. Ovulatory dysfunctions can be severe enough to prevent conception and ablation or only a contributing factors, that is oligoablations. However, because of cycle can replace up to 20%. Menstrual history, number of methods to tell the ovulation happening or not. Each available test is useful, no one is the best because menstrual history alone often is sufficient to establish the diagnosis of oligo and anovulation. Ovulatory women generally have a regular, predictable menstrual cycle between 21 to 35 days with menstrual flow that is consistent in volume, duration, typically a recognized pattern of premenstrual menstrual symptoms. Conversely, menstrual cycle is anovulatory women generally are irregular, unpredictable, infrequent, very flow characteristic. Women with regular menses almost always ovulatory. Almost always. Remember this thing. Women with regular menses, if she had a regular menses, that means it is almost always ovulatory. Women with irregular, infrequent menses may ovulate but not consistently. Irregular infrequent menses may ovulate but not consistently and don't require specific diagnostic test to prove, which already is obvious. Basal body temperature is body temperature under basal conditions. Synthetic progesterone commonly used to induce menses in amenorrheic women, methotrexate, acetate, nor ethindrone acetate have been similar thermogenic property. It also raises basal body temperature. The ideal basal body temperature recording is distinctly biphasic and reveals a cycle between 25 to 35 days in length, with menses begin 12 days or more after the rise of temperatures. In cycle monitor BBT, the interval highest fertility span the 7 days interval immediately before the mid-cycle rise in BBT. The coital time can be optimized by suggesting intercourse on alternate day beginning 7 days before the earliest observed rise in BBT, ending on the latest day it has been observed. Serum progesterone, consider the serum progesterone measurement is the simplest, most common objective and reliable test of ovulatory functions as long as it is appropriately timed. The progesterone level generally remain below 1 nanogram per ml during the follicular phase, rise slightly on the day of LSS 1 to 2 nanogram per ml, steadily thereafter peak 7 to 8 days after ovulation, the decline after the again over the days preceding menses. A progesterone concentration less than 3 nanogram per ml. If remember, this is a very important questions. Every time they will ask that progesterone concentration less than 3 nanogram per ml implies an ovulation, except when drawn immediately after ovulation or just before the onset of menses, when lower level naturally might be expected. When is the best time to measure the serum progesterone level? Consider document ovulation. Either the serum progesterone level should be drawn approximately 1 week before the expected onset of menses, when the concentration is at or near its peak. Contrary to the popular belief and practice, cycle day 21 is not always the best time to measure the serum progesterone concentration. If always try to do 1 week before the expected onset of mens. 1 week before the expected onset of mens. The cycle day 21 is a good choice for women with cycles lasting approximately 28 days, but poor choice for women 35 days cycles. The normal ovulatory cycle is 25 to 35 days long. Exhibits 35 to 15 days luteal phase are the extreme normal. 10 as late as day 22. Population cycle day 10, day 21 plus 11 day after ovulation. Consider peak when they again match day 20, day 21 only before ovulation. The best time to test will vary with the overall length of the menstrual cycle. The aiming for approximately 1 week before the expected mens. If the mens does not come in 7 days after 7% reading or less than 3, it is only repeat the test. There are no consistent minimum serum function that define normal luteal functions. Mid luteal serum function consent cannot define the quality of luteal function, has a little below in the document. The urinary LH secretions, let's pick. Ovulation generally occur 14 to 26 hours after detection of the LSS, almost always within 48 hours. Consequently, of greatest fertility include the day of such detected in the following 2 days. Though after the first positive test, generally the one best time to intercourse, the insemination. Endometrial biopsy luteal phase deficiency, in the absence of treatment with excess in progesterone, synthetic progesterone secreted in recent ovulations. In the past, endometrial the diagnosis of luteal phase deficiency is considered basic element of the infertility, but no longer they are recommended. The fertility, sterility, luteal phase defect. In some, histologic endometrial dating cannot guide the clinical management of women with infertility failure, has no place in the diagnostic evaluation in fertility. Previous will do NSAID because treatment with prostaglandin synthesis inhibit NSAID can disrupt the ovulatory process, predispose to luteinized unruptured follicle. Their use base limited to the menstrual phase of the cycle, attempt to conceive. Summary assessment of ovulations. The postcoital test no longer recommended. What are the myoma causing infertility? Displacement of cervix, decrease the exposure to sperm, enlargement or deformity of the uterine cavity, interfere with sperm transport, obstruction of the interstitial segment of the fallopian tube, distorted adnexal anatomy, interfering with the ovum captures, distortion of the uterine cavity or increased abnormal myometrial contraction, inhibiting sperm or embryo transport, impair uterine blood flow, chronic endometritis, decrease endometrial receptivity, interfere with the implantations. In some, the accumulated body of evidence indicate that submucosal myoma reduce the IVF success rate approximately 70%. Remember, the submucosal reduce the success rate 70% and the intramural myoma by approximately 20 to 40%. Subserosal myoma has no adverse impact on outcome. The 70-40, remember the 70% is submucosal myoma, intramural has 40%, 20 to 40%. Submucosal myoma increase the risk of miscarriage after successful IVF at least threefold, and intramural myoma by more than half. Decision regarding the management of infertile women with asymptomatic intramural myoma are among the most difficult clinical judgment. They must consider not only the size, number, location, and the risk of benefit of the procedure, also its duration, infertility, ovarian disease, or other infertility factor that will may require. The careful selection of the patient most likely the benefit from myomectomy is far more important than the choice of surgical technique. The procedure little low like benefit and relevance. Intrauterine dilation, Asherman syndromes. Remember all these things. Hysteroscopy is the diagnostic, hysteroscopic ratio lysis. Endometrial polypectomy will do. The taken together, available evidence suggests that polypectomy may improve reproductive performance in infertile women. The treatment must be individually depending on the size of the polyps, associated symptoms circulating of the infertility. Chronic endometritis, you will give infections. Tubal factors, lesions, history of pelvic AID, abortion, appendix, tubal surgery, struggles with the tubal damage. Ten to 12% up to 1%, 25 to 35%. Chesty laparoscopy to classic.